Thanks for the kind introduction. Magandang hapon po sa ating lahat. First of all, let me thank the De La Salle University Institute of Governance for this opportunity to join you today. This presentation is about sustaining nutrition for the first 1,000 days of life during COVID-19 pandemic and beyond. I'll be sharing our experience in our city nutrition governance project currently being implemented in 3 cities. This is the outline of my presentation. First, I will give a background on the framework of the intervention, then how the framework is operationalized. Then I will present the situation in the LGUs concerned before COVID-19 came, the disruption it caused, the LGU response, and some lessons learned and possible ways forward. Let me start. Back in 1991, health services in the Philippines were devolved to local government units. Most local government units were unprepared for this new responsibility. Most had insufficient resources to maintain the quality of health services expected of them. This resulted in what is known now as fragmented delivery of health services and serious health inequities between income classes. Among the poor, access to health services is usually limited to those offered in rural health units or barangay health stations. But the key to a better rural health system, as we all know, is the mayor, who has the authority and responsibility to plan and implement local health policies and programs. The Zuellig Family Foundation therefore focused on developing health leadership capacities to transform local governance and health systems. It was important for the mayors to understand the urgency of improving the local health system, and this can only happen if they take very active role in it at hindi ho ipaubaya lang sa MHO at iba pa o kaya sa Nutrition Action Officer. Kailangang pangungunahan ni Mayor o ni Gov. CFF's development strategy, called the CFF Health Change Model, is premised on the assumption that local health leadership, especially that of the mayor and the municipal health officer, is the key to changing local health systems that lead to better health outcomes for the poor. These health outcomes will improve if health inequities are greatly reduced. Health outcome is a function of people's access to health services. Just how responsive health services are is largely determined by the existing institutional arrangements that, in turn, are made possible by a responsible leadership. Responsible leaders craft policies that make health services more accessible to the poor. The thesis of the Foundation's health change model is that a transformed public leadership would reform the existing health systems to address health inequities and produce better health outcomes for the poor. To operationalize the health change model, the CFF intervention involves leadership capacity building for the mayors and their health team. During the training, mayors and the health officers are given structured learning exercises to help them become bridging leaders. It is followed by a practicum where local government participants actually work on reducing inequities. Here, they are guided by the Municipal Health System Technical Roadmap developed by the CFF, which is based on the WHO's 6 building blocks of health systems. Each building block has a set of indicators, the status of which serve as basis for the coaching and mentoring sessions of municipal health leaders. During practicum, they are given coaching and mentoring advice so that they can apply their bridging leadership competencies to transform their local health systems. In 2015, CFF, in partnership with another philanthropic organization, used this approach in 2 geographically isolated and depressed areas for 24 months. These are actually 2 municipalities, one in northern Samar and one in Romblon. It had positive results, as stunting was reduced by 2 percentage points per year. Coming from this experience, CFF then went on to adapt the lessons learned to the City Nutrition Governance Program in partnership with Nutrition International. The current intervention started in 2019 and implemented in the cities of Puerto Princesa in Palawan, Tacorong City in Sultan Kudarat, and Tagum City in Davao del Norte, in partnership with the respective city governments, the Department of Health, and the National Nutrition Council. The project's objectives are to increase the capacity level of LGUs to integrate delivery of F1KD services, increase the leadership and technical competencies of the health and nutrition champions and workers, and improve nutrition data management system. Preparation in the cities began in February of 2019. From August 2019 to February 2020, a series of capacity building on nutrition leadership and governance were held. Total of 3 city mayors, 50 City Nutrition Council members, and 192 Barangay Nutrition Committee members were trained on becoming bridging leaders. A 4-month practicum period held from September to December 2019 complemented the training. A deep dive was conducted, and this provided the mayor and his team better appreciation of the community situation. This period opened opportunities for them to consider and implement local policies and projects that would lead to nutrition systems improvement. The project was supposed to end this September 2020. However, given the pandemic, it has been extended to April 2021 to ensure that cities have ample time to complete the planned activities and sustain gains made in 2019. Having seen and been moved by the realities of their vulnerable constituents through the deep dive activity and guided by the scorecard on the status of their city health system, the mayors went on to lead the intervention on the first 1,000 days. While not uniform in their actions, they all provided the necessary leadership. Their most important actions included engaging their internal and external stakeholders. The mayors gathered their department heads and led them in crafting a vision and strategies for nutrition and providing the necessary enabling environment, foremost of which, as we all know, was funding. They also advocated for the F1KD to the barangay captains and engaged civil society organizations in amplifying the resources for food security and maternal services. Let me repeat what these mayors uttered as an expression of their commitment. Mayor Byron said, hanapin natin ang mga malnourished na buntis. Mayor Rillion also said that in a perfect situation, gusto nako zero jud ang malnourished diri sa Tagum. If dili siya ma 100%, at least na akita reduction o dili na motaas. Damgo gyud nako na kaugbaon is for a healthy Taguminos. And the mayor of Montilla of Tacorong, tinataya ko ang aking pagkamayor sa laban kontra malnutrasyon. These statements from the mayors actually provided the impetus for the rest of their team to really pursue the transformation of their local health system. The concrete leadership actions of the mayors are shown on the right side of the screen. And this ranges from increasing their ability and ensuring, in fact, that all the departments and the different units of the city government are able to collaborate and integrate the delivery of their services for their target nutritionally at risk women and children. The positive momentum of the intervention was, however, disrupted when COVID-19 and the prolonged lockdown came. Suddenly, the health system activities, delivery of the basic services were halted. The planning, training, monitoring, and other services gave way to the urgent COVID-19 response. As the system was recovering from the shock, it was able to operate only at a portion of its previous capacity. As a result of these disruptions in the governance systems, people's lives were also disrupted. With the loss of livelihood came increased poverty and hunger, both in intensity and incidence in some places. How did the LGU respond? Una, hindi nila pinabayaan ang F1KD program, especially the nutritionally at-risk population, ang mga nanay at ang mga babies. They pursued their commitment to the F1KD population and put their systems back to work in continuing basic health and nutrition services. Technical staff well-versed with policies looked to various resources and did not wait for national guidelines on resuming their delivery of services. Thus, they were able to resume at least some, if not most, of the F1KD services as early as the end of March and gradually scaled it up. After the initial pull-out of the health and nutrition workers for COVID-19 response, additional human resources were hired for the purpose, and the health and nutrition workers were returned to their posts. They continued delivery of services by going to the homes of their clients, monitoring them, and distributing micronutrients, food supplements, and food packs. Proper health protocols and safety were observed. Nutritionally at-risk pregnant women and severely malnourished children were paid home visits by a doctor. The database on F1KD population put in place before COVID facilitated this accelerated delivery mode. The different LGU departments already set up on integrated delivery of services jointly targeted the F1KD population in the pandemic response. Households with pregnant women and malnourished children were prioritized in the distribution of relief goods and agricultural inputs for backyard food production. Pook leaders continued to assist in information dissemination to these households. For the general population, the LGUs facilitated access to food and livelihood through home delivery service of fresh produce, establishment of kadiwa centers, and sustainable community family food production projects. Since hindi naman kaya ng LGUs ang lahat dahil sa dami ng nangangailangan, partnerships with various groups and private sector were established and strengthened. This generated additional resources vital to sustain the interventions. To date, this is a continuing effort and challenge that LGUs are addressing. So what insights can we draw from this? As we all know, emergency disrupts people's lives. The situation becomes more difficult if health and governance systems are unable to function. And it is always the most vulnerable who are adversely affected. Preparedness, therefore, to deal with emergencies is critical to avoid widening the gap between people's needs and attainment of these needs, especially among the most vulnerable. The work of the three cities prior to COVID in terms of putting in place the F1KD systems, such as the leadership support, knowing who are the nutritionally at risk, having a roadmap to guide actions to effectively deliver integrated F1KD direct and support services, allowed them to bounce back faster and continue providing the services to NARS. Another point, the state's responsibility for the welfare of its constituents is largely borne by the local government units. The pandemic situation highlighted the importance of a strong and resilient local health and nutrition system, which means the ability to continue providing the services even with the disruptions, respond to increased or surge of demand, and also there's a need to highlight that certain leadership role and competencies, which I will elaborate later, in times of the pandemic are crucial. The pandemic highlighted the need for the capacity to continue essential health and nutrition services in an emergency, with the inclusion of the most vulnerable in order to sustain good health and nutrition outcomes for all. As we have seen, this huge task entails a multi-stakeholder action coupled with accountability. In this arrangement, the local government has the unique critical role of integrating the interests and efforts of the stakeholders. To do this, the local government unit would do well to A, understand the critical knob and know what to do with leaders who are competent to govern complex systems. B, make decisions towards cohesive and clear actions with the aid of reliable data. And C, be capable of sustaining good health and nutrition by having its targets understood and owned by the communities. And to put all of this together, LGU leaders who carry out the following effectively are necessary. The leaders have to show the way in one, owning the issue, two, planning for clear results, three, communicating risks to their constituents, and fourth, engaging communities and partners to create stronger institutional arrangements and forge trust and confidence in the community. These competencies must be developed by our local leaders to make their governance systems resilient and better prepare them for future shocks. These lessons learned are further elaborated in the Mayor's Manual for Strengthening Local Nutrition System for the First 100 Days. While this manual was based on the old normal situation, it still offers applicable guidance even in this new situation where we are all in. It will be updated in time as we progress through the F1KD interventions in this time of pandemic. We likewise invite colleagues, friends, and partners to contribute their insights as well as their suggestions on how to improve these manuals and references, which is among the resources that are available now for our local governments. Thank you for your attention.